Thanks, Liz, for that very, really warm introduction. So you have to recognize yourself sometimes. Um, but so I'm here to talk about eMental health. And so, how many of you have heard the term eMental health? Is right? Okay, well, majority of you have. So just thought of the other naming conventions around the world. We talk about eMental health and addiction, e-therapy, blue prescription, digital mental health, online mental health, internet-based interventions, online self-management. And we're talking about the same elements in terms of eMental health because that's a preferred sort of language which we have for Canada, Australia, and New Zealand. In UK, it's more accepted to be digital mental health. In terms of definition, because it does come down to what is the definition, what are we talking about? So, definition, the most widely accepted definition is mental health and well-being services delivered or enhanced through internet and related technologies. And then we have a definition by World Health Organization as well. So in terms of adoption and national trends, New Zealand, a nation of only 265,000 square kilometers, 4.7 million people. Look at the last 18 years of whether it be sparks from Sally Mary at the University of Auckland, whether it be the National Depression Initiative fronted by Sir John Kirwan, the Journal, the Big White Wall, 1737. We got Poor Waitanga, we got Beating the Blues, we got Auntie D, a gambling helpline, Just a Thought, which was released very recently. So there are a range of things. It's quite amazing. The appetite for adoption of innovation in New Zealand is probably we are one of the leading adopters of innovation when it comes to paving the way. So in terms of, is it just New Zealand thing or is it something which is getting the worldwide attention? Only last week, or the week before last, 4th of November, in Dubai, World Economic Forum, the main theme was around eMental health, and this is how we can empower 8 billion minds by 2030. So it's a very audacious agenda and the move which World Economic Forum has. So in terms of, I do not know if some of you know Professor Shekhar Saxena. He was the previous executive director for World Health Organization Mental Health Unit, and he talked about when it comes to eMental health, all countries are developing countries. So there's nothing called that New Zealand is ahead or Canada is ahead or US is ahead. I think we're all learning as we go along. But what is exciting as opposed to 18 years ago, when you look at the trends, and I always think what's happening in Silicon Valley is indicative of the broad agenda, how it's shaping around the world. So Silicon Valley, 20 years ago, there were hardly any investments in eMental health, because it was left up to the NGOs and the sector to just do low sort of key projects. But today we're seeing some big money being poured into eMental health, and that's indicative of things to come. So in terms of domain, what that eMental health domain consists of, we talk about first and foremost is information provision. Sometimes I don't need full-blown treatment or interventions. Sometimes that little nudge in my life, I'm going through some very rough patch because just been made redundant from my work, not feeling up to it because I can't afford to pay my mortgage repayments. So all I need is some information to get to the right place on my own, and that's enough. So where do I get that credible information? In a layperson's language, which I can understand. I don't need to see language which is over-clinicalized or over-pathologizing my situation at that point in time. Second one we talk about is engagement. And engagement is not just during the treatment interventions, but also looking at the pre-treatment and the post-treatment. So we're talking about, this is also, some of you may be familiar with that, things like PROM and PREM, which is patient-reported outcome measures and experience measures. Then we look at the treatment interventions. We sometimes don't like the word treatment intervention because I call it an intervention, because sometimes it could be just about well-being as well. Then we have primary care, so mild to moderate, or if my situation is rather quite, challenging, it could be hospital settings, which we call it the acute settings. So it's a step care modeling. So there are different solutions for different needs which people in a nation might have. What is very interesting to see is also around social support sort of aspects of it. So social support is where if I am being stitched up and sent back to the same dysfunctional environment which I live in, where there's alcohol, there's a domestic violence, and there is unless I receive some meaningful interventions and I get back on my feet by way of reconnecting with my social networks and the things which were healthy routines for me. And so we've shown with some of the studies internationally, particularly in Canada, that you can delay the rehospitalization by 12 weeks. And there are simple text-based interventions. So this wanted to illustrate just the challenges, and I'll give you an Australian example. We have examples of New Zealand as well. In 2017, 3,128 young Australians took their life. 75%, 2,346 young people had not sought help from any health service in Australia. So that is primary care, secondary care, so we're talking about staggering number of people. So the challenge is, so how do we reach out to the people who are not reaching out to services at a time and place and mode of their choosing in a non-stigmatized manner? Because some of these young people are not seeing that as a mental health challenge. So there's no point in talking about mental health to these young people. So unless we speak the language at the time and place of their choosing, we're not gonna. So the biggest challenge for the governments around the world is how do we engage? Who are these people? Where are they? And how do we connect with them? So we talk about one of the things is a top-ranked study, which is in JAMA, April this year. It was published. It looked at the 36 apps in depression and smoking cessation, which have been prescribed by the doctors, and 29 of those apps shared patient data with the third parties. So that's staggering. So how many apps are there right now? So as of today, there are 327,000 health apps globally available. 65% have not been updated for the last 18 months. All right. 15%, only 15% of those meet minimum standards. Now, if you are the commissioners of the health services, whether it be DHP, with the Ministry of Health, the Health Promotion Agency, PHO, how do you know which 15% you need to focus on? Which ones are those 15% of those apps? So it's a challenge for the system to understand how to navigate the complexity. We know adoption of the technology, whether we look at the smartphone utilization, from 64 million smartphones in 2006 to 3 billion now. So that's staggering, and the rest of the utilization rates are there, and we probably know about most of this. But what is more important is we all have these phones. We call it a phone, all right? Let's look what we do with the phone. Number one is texting. Number two is email. Number three is Facebook. Number four, this is the research data. Number four is camera. Number five is reading news. Number six is, I don't do online shopping, but that's number six. Check weather, WhatsApp, banking, YouTube. Where is making a phone call? Number 11. So that's how we use phone today. So the point here is not about how we're using the phone, but is looking at are we speaking the people's language in that order? Because that's where people are. There's no point in saying you must ring a helpline. If that's a number 11 activity, we are not connecting with the people in what they are doing in the environment where they are. How we are looking at the policy, strategy sort of context around the world. We got Australia probably leading the way, to be honest. 2010, they had an eMental strategy. They are reviewing it right now. And they have got eMental Health Review, which happened in 2014. Right now, there is a major program of work with a huge fiscal envelope behind it, currently underway by the Department of Health in Australia. Canada has taken a lead at a federal level, also at the provincial level. One of the leading provinces is Newfoundland and Labrador. UK has nice guidelines. We have US has got non-binding recommendations, guidance for FDA on mobile medical applications, and New Zealand only this year has taken the steps towards developing eMental Health framework for New Zealand. So I liken it to would you buy a car for yourself or your children which has got no warrant of fitness? So how do we know what works? Where is the clinical governance? Who says the content is safe and effective? Um, so these are some of the measures, but also looking at one of the initiatives by Health Promotion Agency in New Zealand, looking at not everyone has access to the data plans. So looking at the remote and rural areas of New Zealand. So, and this is an amazing initiative called Zero Rated Data, and some of the websites are part of this trial that's being run in New Zealand right now. So there are a range of sort of interventions, like in Canada, they have developed an eMental health implementation toolkit for all Canadians, all 13 provinces across Canada. A practical guide, and I think we have a relationship, very healthy relationship, where the Canadian government has agreed to share all of these resources at no charge with New Zealand. So that means we can learn and sort of work with each other. So these are some of the points which Liz talked about in terms of the 5 key elements. So getting implementation right is not just about academics or the industry alone. This is about quite a careful consideration across the scientists which are developing evidence-based approaches. We've got some of you leading experts are here in this room right now. Then we've got consumers, which is people with the lived experience. If it doesn't work for the people with the lived experience and their families, it does not work at all. So their involvement in the design development is very critical. And I say, why do all of this if it's not solving a pain point in Wellington or in Canberra or in Ottawa or in Washington, D.C.? I think as much as, so they need to be scalable, they need to address some pain points. So we've got policy alignment we're talking about, looking at also workforce development. Just because we have a shiny toy syndrome, we keep buying things and commissioning things, and the people at the coalface in primary care, secondary care, they roll their eyes, those docs. They say, oh my God, what have they purchased now? Because nobody has considered them, the pressures they are working under. So workforce development is a very big part, and I think unless we do get that right, I think we'll keep missing the point. And then industry. The best country in the world, which I've seen the industry's involvement such a beautifully done in such a beautiful way, is Sweden. They have the vendors, IT vendors, and insurance companies, everyone in the room. And I just think here we see IT people or the insurance people or other people as if they are some foreign entities, and we talk about conflict of interest. And I think there are so many different providers, EMR systems in secondary care and primary care. There are apps, there are patient portal. Unless we work together, we're not going to get it right. And patient is saying, don't you talk to each other? So we have got success by design. I would talk about it in detail because I've touched on it some shape and form. But I liken it to each one of us are leaders. Otherwise, you wouldn't be here. And I liken each one of us to be like being the conductors who have a responsibility to create symphony. We don't need to play all the instruments ourselves. Let each maestro play their own instrument in sync with the others. That's the only way to create symphony. And the problem is we got so many people who just don't want to collaborate. So that's the only way to create a value from these humble resources which we have. And this is my last slide, which is biggest innovation in mental health in recent time has come out of Zimbabwe, a friendship bench, a very simple concept where they are a nation of 14 million people, only 12 psychiatrists for the entire country. Now, so they came up with the idea. There are so many grandmas and people willing to help, and I get approached even in New Zealand, how many people saying, how can I volunteer, how can I help? So they came up with the idea of friendship bench, and here people just simply sit and talk. So what are the key elements of the compassion? Don't underestimate the power of listening. It's very powerful. Each one of us can be the therapist. We don't need to look for the therapist out there who's going to see me for an hour. Actually, empathy. Somebody just saying, I'm so sorry you've been through so much. Just words of kindness of being nice. Practical help and advice. I didn't need to go through my childhood trauma when I lost my job. I need some practical help as to how am I going to pay my mortgage bill next week. All right, so we're talking about practical. So eMental Health is nothing else but virtual friendship bench. That's what I think it is. And we need to simplify it. It's not technology. This is about speaking the consumer's language in the context of what I talk about, the order of how people are communicating. Unless we communicate, and just keep it simple, and it is a virtual friendship bench. Thank you so much. Sure.
Well, you've actually sped through that, so we've got a lot of time for questions. So I hope you will have lots of questions from them. Would anyone like to start us off?
The idea of the virtual friendship bench. I teach undergrad students. There are thousands of them in the university wanting to help, and I wondered if you wanted to comment on movements in New Zealand about that micro-volunteering idea, or how we scale up and technologically enable that wish to be on the virtual kindness bench.
Yeah, I think you touched on something which is very dear to my heart, and I think I look at the amount of people approaching me on a regular basis. There's no, I think it requires coordination, to be honest. There is no shortness of the people wanting to come and help. So I feel the timing is right. So if it doesn't happen now, I think we will miss the, and I'm not going to name the region, but in the context of this talk, the small community in Southland, and the last 3 days has lost 4 people. One nurse working in a hospital. I was called personally to provide some intervention there. 3 young people. One young person was 11 years of age. I've got 3 children, all right? I cannot imagine an 11-year-old boy taking their own life. Now, the CEO who called me is a stoic South African person, but he was crying on the phone. He said, I cannot handle this anymore. And this is a community of 12,000 people. Everyone knew all those 4 people. Just think of the trauma that. So I think that is more and more required. We need to do something. I think we just get so focused on Auckland, Wellington, Christchurch. There are not everyone lives in those larger communities. They are remote and rural areas. Their challenges are different, and I think the more we go and actually band together, so I'd be more than happy to explore with you, and I think we need to do something.
It's soft. Can you tell us a little bit about the eMental Health framework work that you're doing, and where you see that sort of going? What's the emerging thinking around that? I know I'm from the ministry, so I should know this, but I know we've announced that it's coming, so I'm just interested in where you think that's headed.
I think it's something we should have done years ago, to be honest. So, but it's never too late. I think I applaud Ministry of Health for the leadership that's coming, getting it right, and it goes to the point which I was talking about: 327,000 apps. We don't even know right now, whatever we have in the adoption. I talked about how many are already working in the country. We don't even know how many of those are safe. So first and foremost would be around safety of those apps. Are we confident as a nation those apps are effective? So I was asked a while ago, but isn't Health Navigator already doing that? I said, you gotta be kidding. For a one-off grant of $80,000, you're expecting Janine Bancroft to do the cyber security check on all those apps? That's a joke. So what we are talking about here is a step in the right direction, and I always say we can get it right either by default or by design. And I think what we started with the eMental framework is by design, and there'll be a lot of recommendations, and there'll be subsequent pieces of work which Australia has been doing since 2010. So there are pieces of work around standards, around certification, which will be further iterations of the eMental framework.
I've got a question for you, Anil, and I loved how you were talking about the workforce planning for eMental Health, and I was just wondering if you had any more ideas to share about that.
Workforce planning, and I think because my work is so integral to the actual delivery, so we specialize in implementation rather than the university end, but we work with the university very close because unless you have them as part of the ecosystem which I talked about. And most of my colleagues who are frontline clinicians, and most of them are some of the nicest people I've ever met in my life. And each one of them are frustrated around communication. Why didn't anyone consult? What is this bloody new thing? And what do I do? And 9 out of 10 times, nobody uses whatever you throw at them. And then people are uptake is low or it's not working. Reality is heavy. We don't understand implementation. One of the key principles of implementation is change management. Working with the people, taking people on a journey, workforce development is such a big part. And I think unless we get that right, and so the organizations like TIPO would do fantastic work. But I think no one agency on their own can do it. It's each one of our responsibility in whatever the commissioning roles we have within DHPs, PHOs, Ministry of Health, to get it right by design.
Very good. We have the last question.
Kia ora, Anil. My name's John. I'm a GP from Auckland. I guess I'm interested in how you are able to scope eMental Health, because obviously, as you've illustrated, it touches so many other things. It touches justice, income, housing, all those other areas. So when you are just trying to address mental health, trying to create an intervention for a specific piece of that, you obviously miss all those other areas too. So it seems like a really big challenge to be able to pick something to go for when there's so many other things contributing.
I think that will come with time in terms of the maturity of us, how well we collaborate. At the moment, there's only one project which I'm aware of that's in Gore and in Clutha region. That is called Hokanui Huanui. It's a Hokanui Highway, is the name of the project, where Ministry of Health, Education, Justice, Police, everyone working together. It's when there are meetings, it's so nice to see people from so many ministries together in one room. So I think, but there is a lot to be said. Why only one project working along those lines? Why not? I think what I find is rural and remote communities are much more resilient and much more innovative, and they're more willing to give it a go because they know if they don't do it, nobody else will come to their rescue. So they band together much tighter as a community. In Auckland, I'd still be doing a proposal to go to some committee which is postpone the meeting pre-Christmas and then goes to the March meeting. And I think we have made it overcomplicated for each one of us. So some of these, how we prioritize these things are also dependent on what the need is. If you look at the last suicide stats, 71% of the completed suicide in New Zealand are men. So of course the prioritization becomes how do we reach out to the men? Then there are sub-factors, so then we keep going. So that's what the prioritization process determines what ends up being delivered and implemented.
So that concludes this keynote session for today. I just want to thank Anil for your time today. I know that